VSD, ventricular septal defect. VSD, most common form of congenital heart disease. 1.7 is to 1000 live birth, 15 to 20%. Now, what is the anatomy of ventricular septum? Small membranous portion, small area immediately beneath the aortic valve. A large muscular portion. Three components of muscular septum. One is inlet septum, outlet or infundibular or conal septum. Another is trabecular septum, that is anterior, posterior, mid and apical portion. Now, what are the types of VSD? According to location and margins, membranous VSD most common 70%. Outlet or infundibular or conal or supracrystal or subpulmonary or subarterial doubly committed VSD 5 to 7%. Inlet or AV canal 5 to 8%, located posterior and inferior to perimembranous defect beneath the septal leaflet of the tricuspid valve. Another is muscular or trabecular VSD. Occurrence is 5 to 20%, commonest towards the apex. And fifth type, that is Garbody defect from left ventricle to right atrium. According to restriction patterns, VSD is divided into restrictive Vsd, that is small significant pressure gradient between LV and RV. Pulmonary to aortic systolic pressure ratio less than 0.3, QPQS ratio less than 1.4:1. Moderately restrictive VSD, here shunt QPQS ratio 1.4 to 2.2:1. And non-restrictive VSD, where QPQS ratio more than 2.2:1. According to the size of VSD, it is divided into small, medium and large VSD. When size is less than 5 mm, it is small. When size is 5 to 10 mm, it is medium. When size is more than 10 mm, it is large VSD. Now, presentation of VSD. Small VSD asymptomatic with normal growth and development. Moderate to large VSD, delayed growth and development, decreased exercise tolerance, repeated pulmonary infections, congestive heart failure common during infancy. With long-standing pulmonary hypertension, cyanosis clubbing, if pulmonary vascular obstructive disease or Eisenmenger syndrome. Now, physical findings of VSD. Small restrictive VSD, second heart sound normally split. P2 is not accentuated. There is pansystolic murmur accompanied by a thrill. In case of large VSD without pulmonary hypertension, in infancy and early childhood, due to increased pulmonary blood flow, there is hyperdynamic apex, third heart sound due to volume overload, MDM at apex, systolic murmur, soft, short, not associated with thrill, P2 normal. In case of large VSD with pulmonary hypertension, in older children and adults with significant elevation of PVR, here apex not hyperdynamic, third heart sound and MDM not audible, ejection systolic murmur, second heart sound closely split with a loud P2. Large VSD with Eisenmenger syndrome. In that case, single P2, pansystolic murmur of tricuspid regurgitation. Early diastolic murmur of pulmonary regurgitation, also called Graham-Still murmur. Single P2 is due to equal pressure in the ventricle with a large communication converts to a common chamber with equal ejection time. Now, special points regarding Vsd. Infundibular Vsd or subaortic Vsd Due to herniation of aortic cusps, air may found, and the cusp normally involved is RCC. Quality of Vsd murmur, pansystolic murmur, loud and harsh pansystolic murmur. Investigation of Vsd. We can do ECG, chest X-ray PAVU, 2D M-mode color Doppler, echocardiography, cardiac catheterization and other investigations. What are the ECG findings in Vsd? May be normal in small and medium sized defects. There may be left ventricular hypertrophy and left atrial enlargement without pulmonary hypertension. In large Vsd, there may be right ventricular hypertrophy, biventricular hypertrophy, that is Kurzweil phenomenon. RVH only in case of increased PVR. P pulmonally incomplete RBBB or complete RBB present in case of increased PVR. Now, what are the chest X-ray findings of Vsd? May be normal, that is Roser effect, may be normal in Roser defect, cardiomegaly with LB type apex due to volume overload, pulmonary conus full, main pulmonary artery dilated, LA may be enlarged, plethoric lung field, large defect with large left to right shunt with increased pulmonary blood flow, pruning of pulmonary artery and oligemic lung field present if pulmonary hypertension develops. What are the echo findings in Vsd? In case of membranous Vsd, apical 5-chamber view shows just below aortic valve, parasternal long short axis view related to tricuspid valve at the level of aortic valve. Great vessel level 9 o'clock position. Inlet Vsd, apical 4-chamber view or subcostal 4-chamber view just beneath the aortic AV valve. Parasternal short axis view at the level of mitral valve in the post IVS between mitral valve and papillary muscle. Infundibular or outlet Vsd, that is supracrystal or subpulmonary, parasternal short axis view lies under the pulmonary valve in 2 o'clock position. In case of infracrystal or subaortic Vsd, that is top-like Vsd, parasternal short axis view shows the Vsd lies under the aortic valve in 10 to 12 o'clock position. In case of trabecular Vsd or muscular Vsd, the echo shows apical and mid portions seen at apical 4-chamber view and parasternal long axis view. Anterior and posterior defects are seen at parasternal short axis view at the level of papillary muscle. 5 things to be mentioned in echo report of Vsd. 1 is location of Vsd, size of Vsd, shunt of Vsd, number of Vsd, associated defects, Doppler gradient across the defect. RB systolic pressure equal to systolic arterial pressure minus Doppler gradient in Vsd defect. So, what is RB systolic pressure? Here RB systolic pressure is equal to systolic arterial pressure minus Doppler gradient in ventricular septal defect. Now, what is the role of cardiac catheterization in Vsd? Indications: accurate estimation of pulmonary vascular resistance, identification of additional Vsds, identification of associated anomalies. Now, what is the interpretation? Oxygen step up in right ventricle, pressure study, mild to moderate defect, RB pulmonary artery pressure and PVR normal, slightly elevated. In case of large Vsd, right ventricle pulmonary artery pressure raised but less than LV pressure, increased PVR. In LBgraphy, low cranial view, we can see perimembranous Vsd. In low cranial view in 45-degree angle, in that is hepatoclavicular view, we can see inlet Vsd. In raw view, we can see outlet Vsd, that is doubly committed or supracrystal Vsd. By doing RBgraphy, we can identify pulmonary stenosis. Now, what are the complications of Vsd? The complications are aortic incompetence, that is aortic regurgitation, subacute infective endocarditis 10% cases, pulmonary infarct and lung abscess, heart failure, pulmonary hypertension. Aortic regurgitation, when aortic valve, that is RCC, prolapse into left ventricle. Combination of pansystolic murmur of Vsd with early diastolic murmur of aortic regurgitation may resemble murmur of PDA. Now, vegetations in infective endocarditis forms in around the defect, that is Vsd, RV side of septum, opposite wall of RV, where jet impinges called jet endocarditis, prolapsed cusp of aortic valve. In these four sites, there is presence of vegetation. What are the associated lesions in Vsd? Pulmonary and infundibular stenosis, PDA, tetralogy of Fallot, DORB, coarctation of aorta, ASD. Now, differential diagnosis of Vsd. The differential diagnoses are mitral regurgitation, tricuspid regurgitation, valvular PS. Mitral regurgitation, pansystolic murmur, best heart near the apex tends to radiate to the axilla. In tricuspid regurgitation, pansystolic murmur increases on breath hold in inspiration. In case of valvular pulmonary stenosis, left parasternal heave, wide variable split of second heart sound, or soft P2 pulmonary ejection click. In case of aortic stenosis, best heart along the left sternal border or at the apex. A2 diminished, soft, accompanied by a thrill, murmur shorter, diamond shaped, innocent murmur. In infancy and childhood, not accompanied by a thrill, ejection type murmur. Another differential is ASD. Now, what is the natural history of ventricular septal defect? Variable influencing natural history. It depends upon size of Vsd, age at evaluation, location of Vsd. 25% of Vsd closes at 18 months or 2 years. 50% closes at 4 years, 75% closes at 10 years. Now, according to the size of Vsd, small restrictive Vsd closes spontaneously during childhood and adulthood sometimes. Up to 60% closes spontaneously, small Vsd. Up to 5 to 10% closes spontaneously, large Vsd. Patients older than 20 years are likely to close spontaneously. Now, in the size of Vsd and pulmonary vascular obstructive disease, small defect, no significant hemodynamic changes. Moderately restrictive defects, LA dilatation, LV dilatation, LV dysfunction. In large defects, LV volume overload, rise in pulmonary arterial pressure, fall in left to right shunting, leads to higher pulmonary vascular resistance, leads to Eisenmenger syndrome. Age at evaluation, a large Vsd evaluated at 6 weeks, more than 80% chance of spontaneous closure. Evaluated after 5 years, less than 1% chance of spontaneous closure. Location of Vsd, according to location of Vsd, doubly committed Vsd prone to develop aortic regurgitation, 25% cases. Now, outcome of untreated Bsd within 2 years of life result in incomplete reversible pulmonary vascular disease, early mortality due to congestive heart failure, chest infection, recurrent lung infection, pulmonary vascular obstructive disease, aortic regurgitation, RVOT obstruction, infective endocarditis. What are the long-term survival follow-up required? Small defects at 25 years, 96%. Moderate defects at 25 years, 86%. Large defects at 25 years, 61%. Eisenmenger complex at 25 years, 41.7%. Now, treatment. What about the treatment of VSD? In cases of medical treatment for small restrictive defects, managed conservatively, followed up regularly. Antibiotic prophylaxis for infective endocarditis in case of small VSD. Treatment of congestive heart failure if develops. This includes diuretics with or without digoxin to see improvement of growth failure 2 to 4 months. Spironolactone, afterload reducing agents such as ACE inhibitor, captopril. High calorie frequent feeding, correction of anemia. No exercise restriction in the absence of pulmonary hypertension. Now, what are the interventional management for VSD? Transcatheter device closure is feasible in muscular VSD and in some perimembranous VSD. Muscular VSD size less than 15 mm. We can do intervention. If muscular VSD size is less than 15 mm, we can do intervention. Adequate aortic rim size and adequate aortic rim size. Now, what is the surgical management for VSD? Indication of surgery: large defects with significant shunt, that is QP/QS ratio more than 2:1 in absence of severe pulmonary hypertension, severely elevated PVR more than 10 wood unit. Presence of a perimembranous or outlet VSD with more than mild AR, aortic valve prolapse. In that case, surgery is recommended. Patients with history of recurrent endocarditis. Patients with Swiss cheese septum, that is temporary palliation with pulmonary arterial bending. Now, what is the timing of surgery? Small VSD without heart failure within 6 months. No surgery without pulmonary hypertension. Large VSD with heart failure with growth retardation despite medical management. Large VSD with heart failure with growth retardation despite medical management within 6 months of age, surgery. If pulmonary arterial pressure more than 50% of systolic arterial pressure, surgery end of 1 year of life. Significant shunt, QP/QS ratio more than 2:1 regardless after 1 year, regardless of pulmonary artery pressure, surgery. So, significant shunt, QP/QS ratio more than 2:1 after 1 year, regardless of pulmonary arterial pressure, then surgery is needed. Older infants, large VSD with increased peripheral pulmonary vascular resistance, then surgery is needed. For VIVA, how to measure RV systolic pressure in VSD patient? Direct estimation of right ventricular systolic pressure is equal to systolic arterial pressure minus Doppler gradient in VSD. স্ফিগমোম্যানোমিটার দিয়ে ব্লাড প্রেশার মাপবো আর VSD এর ডপলার গ্রেডিয়েন্ট মাপবো ইকো দিয়ে। থ্যাংক ইউ।